Good afternoon. My name is Chris Herrick, and I'm the Deputy Commissioner for TDI's Life and Health Division. I'd like to welcome you to the 2022 Virtual Compliance Conference. Thank you for joining us for this webinar on mental health parity. Today's presenter is Rachel Bowden. She is the Director of the Regulatory Initiatives Team for the Life and Health Division. For the Q&A time at the end, Rachel will answer questions that you have during this session. If you think of any, please type them in the Q&A box and she'll answer them at the end of the presentation. Okay, let's get started. And again, welcome and thank you for joining us.
Good afternoon. I'm Rachel Bowden, Director of Regulatory Initiatives for the Life and Health Division at TDI. Today we're going to talk about mental health parity. We'll provide an overview of the federal law and get into the details of TDI's regulations that we adopted in 2021. Okay, today we're going to talk about the evolution of the parity law. We'll get into a high-level discussion of the federal parity law and rules. Then we'll talk about the Texas parity laws passed in recent years, and then get into the details of the federal or the parity rules that TDI adopted in 2021. Those are very similar to the federal parity rules. We'll discuss how the rules compare, the data collection requirement, and then the compliance analyses for assessing quantitative and non-quantitative treatment limitations. So this timeline illustrates how parity law has evolved over the years. Prior to the Mental Health Parity Act of 1996, Texas did have some laws requiring coverage for mental health conditions and substance use disorders, specifically relating to group health plans. And in 1996, the Congress passed the Mental Health Parity Act. TDI implemented rules in 1999 that align with the Federal Mental Health Parity Act and enabled us to enforce that law. The next big milestone was the 2008 Mental Health Parity and Addiction Equity Act, which we call MAPIA. That was a big development, expanding upon the 1996 regulations that we'll talk about a little bit more. And the rulemaking took place over several years. There was an interim final regulation issued in 2010, but then the Affordable Care Act passed, which complicated things a bit. And the final rules that are now in effect were adopted in 2013 and effective in 2014. In recognition of the complexity of implementing the Parity Act, the Cures Act expanded upon the law and required federal regulators to issue some guidance. And then most recently, the 2021 Consolidated Appropriations Act also amended and expanded upon the Parity Act and requiring issuers to perform non-quantitative treatment limitation compliance analyses. And as you can see in Texas, in orange, we've been following along. So in 2011, following the enactment of MAPIA, TDI did update our parity rule to align with the new federal law, but it didn't incorporate all the details of the federal rulemaking since that process was still going on. And then the big milestone for Texas was in 2017, the legislature enacted House Bill 10. And that included broad parity requirements that align with the federal standards. And then our rulemaking process also took several years as we worked through various issues, and we adopted the rules effective 2021. So one note on the structure of the federal law: like other federal healthcare laws, the Parity Act is repeated in 3 sections. Of the federal code and involves 3 different agencies. So for the TDI regulated plans, we really focus on the rules put out by the Health and Human Services Department and CMS under the Public Health Service Act. So those are located in 42 U.S. Code 300GG-26, and the rules are in 45 CFR 146.136. So these are the ones that we pay the closest attention to, but they're very consistent with the laws and rules in the Labor Code, which are enforced by the Department of Labor, and in the IRS Code, or in Internal Revenue Code and enforced by Treasury and the IRS. So those are focused most on employer plans, and whereas the HHS rules are focused on the fully insured plans. So the Mental Health Parity Act of 1996 was a major milestone, but it did have limits. So it applied only to large group health plans, and it only applied if the plan already covered mental health conditions. So it didn't require coverage of mental health, but if a plan did cover benefits for mental health, it did need to comply with the parity standard. The parity standard focused on aggregate lifetime limits and annual limits. So, they couldn't just put a dollar amount cap on how many, the amount of benefits that would be paid for mental health. But that obviously left a lot of other ways that coverage could be different and more limited for mental health conditions. It was focused only on mental health benefits and not substance use disorder. So that was another limitation of the law. So moving on to the 2008 Parity Act, this was the Wellstone-Domenici Mental Health Parity and Addiction Equity Act, which I'll refer to as MAPIA. It was effective for plan years starting in October 2009. It expanded upon the original Mental Health Parity Act to include substance use disorder benefits as well as mental health conditions. And the scope of parity was much broader. So instead of just being on those annual limitations or lifetime limitations, it focused and required parity for all types of treatment limitations and financial requirements. So, your cost sharing, your how many visits, the deductibles, whether you can have a separate deductible. It said no, you have to combine those. You need to treat things equally, and it provided a lot more detailed framework. So the general parity standard is that limits on mental health and substance use disorder may not be more restrictive. And it also required some disclosure requirements about medical necessity criteria, saying that enrollees and providers can request those and that issuers must provide them. So the 2008 parity law was still limited only to large group health plans, and this changed in 2010 with the Affordable Care Act. It expanded the applicability of parity to also apply to individual market plans. And, a lot of individual market plans didn't include mental health coverage, but under the essential health benefits, under the Affordable Care Act, all plans did need to cover mental health and substance use disorder benefits. So that was really a new coverage mandate for non-grandfathered individual and small group plans. So previously, small group plans were exempt from the parity law, but because of the essential health benefits, in order to meet that standard, they also need to comply with the parity requirements. So that left very few gaps in the types of plans that aren't subject to parity. So the remaining kind of gap in the fully insured market was small group grandfathered plans continued to be exempt, whereas individual grandfathered and non-grandfathered plans are subject to the parity requirements if they cover mental health and substance use disorder benefits. In 2016, the 21st Century Cures Act expanded upon the parity law and really directed federal regulators to provide compliance guidance for health plans. The guidance that's been issued has been very, very valuable to, I think, both health plans and regulators in better understanding how to evaluate parity and how to ensure compliance with the parity requirements. It also included guidance to health plans on the disclosure requirements and facilitating, those disclosures for consumers and providers. So helping consumers and providers know how to ask for the requirements, ask for the information that's required by the law. And then most recently in 2021, the Consolidated Appropriations Act again amended the parity law and expanded upon the directives to regulators, but also created a new requirement for health plans to perform and document comparative analyses of the design and application of their non-quantitative treatment limitations and make those analyses available to state and federal regulators upon request. They only provided 45 days from enactment for those comparative analyses requirements to take effect. So as of February 10th, 2021, health plans are required to provide the NQTL analysis to regulators. There's some detail in FAQ number 45 related to the law, but really the compliance guidance that the departments had already published includes what plans need to know in order to do those comparative analyses. There's kind of a 4-step framework for looking at how NQTLs are designed and applied. In addition, it required federal regulators to review at least 20 such analyses each year, and for regulators to publish annual reports summarizing the comparative analyses reviewed and the compliance findings. So the report published in 2022 is linked at the end of this presentation. It's a really useful discussion of where health plans continue to struggle in developing those analyses the way that federal regulators expect. So the federal parity rules are in 45 CFR 146.136. As we discussed earlier, there was an interim final rule adopted in 2010, and then the rules were expanded on a bit and finalized in 2013, effective 2014. The rules lay out 6 classifications of benefits for testing parity. So that provides some framework for the parity analysis. And the test for quantitative parity is that a limit may not be more restrictive than the predominant limit that applies to substantially all medical surgical benefits. So that ends up being a math test, and we'll get into that a little bit later. The rules require that if mental health or substance use disorder benefits are covered, they must be provided in the same classifications where medical surgical benefits are provided. And with respect to any aggregate limits on benefits, like deductibles or out-of-pocket limits, those aggregate requirements must accumulate in tandem. So the medical surgical accumulations are combined with accumulated spending for mental health and substance use disorder benefits. You can't have a separate deductible for mental health that you have to meet, even though you've already met your deductible for medical surgical benefits. The parity rules interpret the federal law's limits on treatment limitations to be really broad. So the requirements apply to financial requirements and treatment limitations, and treatment limitations is interpreted to include both quantitative treatment limitations and non-quantitative treatment limitations. So QTLs are expressed numerically, a number of visits per year, whereas non-quantitative limits limit the scope or duration of benefits without necessarily applying a numerical limit. So a medical necessity requirement, for example, is a type of non-quantitative treatment limitation. And we'll get into more detail in a little while. So moving over to the Texas laws, House Bill 10 was the big one in 2017. In addition to establishing some parity requirements in state law, it also established an ombudsman for behavioral health that's located within the Health and Human Services Commission. And that serves as kind of a one-stop shop for people who are having problems accessing behavioral health care. They can connect with the ombudsman, and the ombudsman can help them, clear the obstacles, whether that means working with a Medicaid plan or, filing a complaint with a TDI regulated plan or an ERISA regulated plan. They'll get them to the right direction and, just generally provide any assistance they can. The bill also established a parity work group charged with completing a strategic plan for improving parity. That group finished their work and was abolished as of September 1, 2021. And then finally, the bill required TDI and HHSC to do a study, collect data, and publish a report. So I've linked that report here. And of course, the parity requirements put into law, we'll talk about the rules that we've adopted to implement those requirements. So House Bill 2595 from 2021 was really, came out of, I think, the recommendations that the parity work group put together. It established October as Mental Health Condition and Substance Use Disorder Parity Awareness Month. And it established requirements for TDI's complaint portal and directed TDI to develop best practices for parity complaints. So, really just trying to make sure that when people have an issue getting coverage for mental health and substance use benefits under their plan, that they're able to complain in a way that's user-friendly and effective. The bill also required TDI to develop educational materials and parity law training sessions related to mental health parity. So this presentation is directly implementing the bill. And it also required TDI to work with HHSC to develop a report on parity complaints and related issues. The study that was enacted by HB 10 had some interesting findings, and while disparities and data findings on their own don't prove a parity violation, they do identify kind of warning signs or issues that might warrant further investigation. So some of those high-level findings were higher utilization of out-of-network care, higher claim denial rates, denials of prior authorization for care for children, higher rates of concurrent review, and higher rates of step therapy for prescription drugs. So, these data points on their own, they're pretty consistent with the anecdotal, complaints that we hear from stakeholders. And, for some of them, there might be good explanations. But, that data was really valuable, and in our implementing our parity rules, we did include data collection requirements so that information will continue to exist for regulators. So getting into the details of House Bill 10's parity provisions, it, like the federal law, it applies to major medical coverage that covers mental health or substance use disorder benefits. So it's not itself a parity or a mental health coverage mandate. Included in the statute is a definition of quantitative and non-quantitative treatment limitations that aligns with the federal rules. It requires plans to provide benefits under the same terms and prohibits imposing limits that are generally more restrictive on mental health and substance use disorder as compared to medical surgical benefits. The law directs TDI to adopt rules and enforce compliance with reference to the 6 classifications of benefits. And it requires plans to define a mental health condition, a substance use disorder, consistent with generally recognized standards. So all of that is really consistent with the federal parity framework. So TDI's rules implementing HB 10 are in Chapter 21, Subchapter P, which is where TDI's parity rules have been since 1999. And the rules include 4 divisions. So the first division is kind of the bread and butter parity requirements that are consistent with the federal rules in 45 CFR 146.136. Division 2 includes a data collection requirement. It's an annual requirement for issuers to submit data. And, it is, similar to the data that was required under HB 10 originally as that one-time study that allows TDI to monitor compliance, identify warning signs, find outliers, and look into issues on a targeted basis. Division 3 of the rules require issuers to complete parity compliance analyses for both QTLs and NQTLs. That's a self-compliance analysis, so there's no annual submission requirement for those, but they do need to share them with TDI upon request. And with respect to the NQTL analysis, that's very similar to the new federal law. And then finally, Division 4 addresses autism spectrum disorder and replaces rules that were previously in Chapter 21, Subchapter JJ. I'm not going to get into the details of those rules. They're very brief because most of the rules were just repeating what was already in the statute. But we did want to clarify, really just how parity applies to the coverage of autism spectrum disorder, which is generally recognized as a mental health condition. And so limitations on autism spectrum disorder are permitted only to the extent that they do not conflict with parity requirements. So, for example, in the Insurance Code Chapter 1355, there is a dollar limit that is permitted to be placed on applied behavioral analysis. The parity law clarifies that, a dollar limit would only be permitted if it met the parity test. So it would be unlikely in that case that it would. So the implementation dates for the rules, as of September 7th, 2021, Divisions 1 and Division 4 are effective. The parity requirements, those really didn't require any changes for plans that were already complying with the federal parity law. And Division 2 has the data collection. Their initial data for 2020 was collected in January of this year, but the ongoing annual due date for the data is July 1st. So for 2021 data will be reported July 1st of 2022. And then finally, Division 3, the compliance analyses, we did provide an extended time frame for issuers to complete those analyses. The quantitative treatment limitation analysis should have been completed by plans as of March 6th. Again, we don't require plans to submit those except upon request. And again, issuers really should have already been doing that analysis to make sure their plans were compliant with the federal law. For the NQTL analysis, I'll get into the details a little bit later, but the first applicable deadline is June 1st of 2022. Again, they don't need to be submitted to us except upon request. And for the plans that are subject to the federal law, the NQTL requirement was effective as of February of 2021. So a little bit about how the Texas law compares to the federal law. The differences are really mostly in the applicability. So the federal law does include a handful of exemptions, exempting both grandfathered small employer plans and self-funded small employer plans. It also exempts short-term limited duration issuers and accepted benefit plans. In Texas, we also exempt accepted benefit plans, but we do not exempt short-term limited duration plans. So that's a type of plan that might be newly subject to parity requirements and be implementing this for the first time with our rules. As we discussed earlier, we don't have an exemption for small employer plans, even the grandfathered plans. So that's another. The grandfathered small employer plans are subject to the Texas parity requirements. Likewise, the increased cost exemption in the federal law, as far as we know, this has not really been used, and we did not include it in our rules. Our statute really didn't specify any exceptions. Under the federal parity law, non-federal governmental self-funded plans, like state and local employer plans, those can choose to opt out of the parity requirements. The federal parity law also doesn't apply to Medicare, Medicare supplement, fee-for-service Medicaid, or TRICARE. They do have separate parity requirements for Medicaid managed care plans, and those are enforced by the Health and Human Services Commission. So the Texas law only exempts accepted benefit plans, and those exemptions are explained in Insurance Code 1355.253 and 1425.001. And finally, we wanted to note that MEWAs are also subject to HB 10 and TDI's rules. So getting into the details of the rules, consistent with the federal law, parity is assessed by comparing benefits and limits for medical surgical conditions compared to mental health and substance use disorder conditions across 6 classifications and subclassifications at the issuer's option. So those classifications are inpatient in-network, inpatient out-of-network, outpatient in-network, outpatient out-of-network. Under the outpatient classifications, issuers can choose to do a subclassification separating office visits from all other outpatient care. And then the last 2 classifications are for emergency care and for prescription drugs. Plans that have tiering within their pharmacy benefit or their networks can also subclassify based on those tiers. In addition to classification, benefits also must be categorized as either medical, surgical, or mental health substance use disorder based on the condition that is being treated. So it's not just, did a psychiatrist perform this service? It's, what is the condition being treated? Because other types of providers can be providing a similar service that might sometimes be used to treat medical surgical conditions and might other times be used to treat mental health and substance use disorders. So for those types of services that can fall into both categories, they should be included in both categories. The classifications and categorizations must be used consistently for QTL and NQTL analyses. And under the TDI rule in 28 TAC 21.2436 F and G, we require issuers to explain within the QTL template the methodology used for categorization and classification. So again, classification relates to the 6 categories: inpatient, in-network, inpatient, out-of-network, etc. Categorization is this service being used to treat a medical condition or a mental health condition. So in categorizing benefits, we look at how those benefits are defined. A mental health benefit is a benefit with benefits with respect to services for mental health conditions. Substance use disorder benefits are benefits with respect to services for substance use disorders. So it is based on the diagnosis. Those benefits should be categorized and defined consistent with the terms of the plan, in accordance with applicable federal and state laws, and consistent with generally recognized independent standards of current medical practice, such as the DSM or the ICD coding systems. And medical surgical benefits are those that are not treating a mental health or substance use disorder. Okay, one of the fundamental requirements for parity is the rule that if you provide mental health or substance use disorder benefits in any classification, you must provide them in each classification where medical surgical benefits are provided. So this was addressed in a case in 2018 where room and board costs were covered for an inpatient stay for medical surgical conditions in a skilled nursing facility, but the plan denied coverage for room and board costs when a mental health condition was treated in a residential mental health treatment facility. The Ninth Circuit Court of Appeals found this to be an improper treatment limitation and in conflict with the federal parity law. Okay, so under Division 2 of the rules, we require issuers to report data annually. Separate submissions are required for each market and plan type. For example, an individual HMO would have data reported separately versus an individual PPO or a large group HMO. Data on claims and utilization review are collected, and the way that data is broken out is so that you can compare the medical and surgical benefits to the mental health and substance use disorder benefits across all of the 6 classifications, plus the subclassifications for outpatient office visits and all other outpatient services. We clarify that the care in providing this data must be classified as inpatient or outpatient based on the place of service. The care is classified as in-network if it's covered under the plan's in-network benefit. So in those special circumstances, when even out-of-network providers must be covered as in-network benefits, that would be treated as in-network for the purposes of the data collection. And in addition to other emergency care, ambulance services that are treating an emergency would also be classified as emergency care. And data must be categorized as mental health or substance use disorder based on the applicable ICD diagnosis code and whether that code is classified as a mental, behavioral, or neurodevelopmental disorder. And then in addition to the data on claims and utilization review that was similar to the HB10 study, the data call also includes average reimbursement rates for select in and out of network services provided by different types of providers. And that data collection was based on a template in the federal self-compliance tool guidance document. So moving on to how we do a quantitative parity analysis. So TDI's rules are consistent with the federal rules on how this parity analysis is done. And in addition to the kind of framework laid out for quantitative parity requirements in Division 1, in Division 3 of the rules, we lay out the methodology and provide a template for issuers to complete that analysis. So the financial requirements and quantitative treatment limitations are really subject to the same analysis framework. They QTLs, so I'll abbreviate just by saying QTLs, that includes both financial requirements and quantitative treatment limitations. So QTLs must meet a two-part test applied by comparing mental health and substance use disorder benefits with medical surgical benefits with respect to each classification. So a type of QTL may be applied to mental health and substance use disorder benefits only if it applies to substantially all medical surgical benefits. And the level of a quantitative treatment limitation that is permitted for a mental health or substance use disorder benefit must be no more restrictive than the predominant level applied to medical surgical benefits. So we'll get into what is a type of QTL, what is a level of QTL, what is substantially all, what is predominant. And before we do that, all of this analysis really hinges on expected payment amounts with respect to medical surgical benefits. So to determine an expected payment amount, an issuer must use a reasonable method. We provide a definition for reasonable method in our rules. The expected payment amount must be based on the total allowed amounts projected for the applicable plan year. It's not limited to the portion to be paid by the plan. If sufficient data is available, the projection must be based on claims data for the particular plan design. And if data is not sufficient, the issuer must use appropriate and sufficient data, such as data from other similarly structured plans with similar demographics. The issuer is required in our QTL template to explain the methodology used to determine the expected payment amounts. Getting into the first part of the test, we look at the type of limit. So a type of QTL is a financial requirement, like a coinsurance, or a quantitative limit, like a limit on the number of days in the hospital. Substantially all means that at least 2/3 of medical benefits calculated based on the percent of the expected claims dollars in the classification that would be paid for the medical benefits subject to a given type of financial requirement or quantitative limit. So in the case of a coinsurance, within inpatient care, is a coinsurance requirement applied to at least 2/3 of inpatient expected claim dollars. If it is not, then that coinsurance could not be applied to inpatient care for medical surgical. It wouldn't meet that substantially all standard. So again, to determine if a QTL is permitted for mental health benefits, analyze the QTLs applied to medical surgical benefits. Looking at all expected claim dollars within a classification, what percent of the expected claims are subject to that type of quantitative treatment limitations? If it's at least 2/3, then we can proceed to the predominant analysis. If it's less than 2/3, then that type of QTL may not be applied to any mental health benefit within the particular classification. If we move on to the predominant analysis, we're looking at the level of the QTL, and that means the magnitude of the limit. So in the case of a coinsurance requirement, a coinsurance of 20% or 30%. Predominant means the level of a QTL that applies to more than 50% of the expected claims dollars for medical benefits within the classification that are subject to that type of financial requirement or quantitative limit. So looking, maybe the coinsurance requirement applies to some amount of coinsurance applies to 80% of inpatient care based on the expected claims dollars. But there's different levels of coinsurance. So some things are subject to 20% coinsurance, other things are subject to 30% coinsurance. What is the predominant level of the coinsurance? Looking at everything that's subject to coinsurance, which gets you to the 50% threshold. So again, to determine if a level of quantitative treatment limitation is permitted for mental health and substance use disorder, analyze the QTLs applied to medical surgical benefits. The proportion is calculated by looking at all expected claims dollars for medical surgical benefits within the classification that are subject to a permitted type of QTL. The expected claims dollars, again, include all allowed amounts, not just those paid by the plan, what percent of claims dollars are subject to the percent of QTL, and what level applies to at least 50% of the expected claims. That is the most restrictive level of QTL permitted for medical surgical benefits or for mental health benefits within the classification. So here's an example of the QTL analysis. So looking at our chart, we can see that PCP and specialist visits are both subject to the deductible. And they together comprise 25 plus 45% of expected claims, which is 70%. And so they meet that predominant or that substantially all threshold. And when we look at which one is predominant, well, they're the same. There's only one deductible. So that is easily met. We know that the most restrictive deductible is $1,000. Looking at coinsurance, we see only the specialist office visits are subject to coinsurance, and those comprise only 45% of expected claims, so they do not meet the substantially all threshold. And that means that no coinsurance requirement can be applied to mental health benefits within the outpatient office visits in network classification. Looking at the copays, we see copays for different amounts for PCP, specialist, and urgent care, together comprising 85% of expected claims. So that 85% exceeds the substantially all threshold. And now we want to see which one is the predominant level. So it's a little tricky because we're no longer working out of 100%, we're working out of 85%. But when we add, when we take the $35 copay, and you take 45 over 85, you get 53%. So that $35 copay meets the predominant threshold and is the most restrictive copay that can apply to a mental health benefit within that classification. And so, for example, a $25 copay could also be applied, but a $50 copay would not be permitted to apply to any mental health benefits within that outpatient office visit in network classification. So again, we do require plans to complete the QTL analysis for each plan design before it is sold. They can use either TDI's template or an alternative tool if it provides the same level of specificity and clearly uses the same methodology. Plans can do a combined analysis for plans with the same plan design. We do define plan design in the rules at 21.2406, number 25. And again, these analyses don't need to be submitted to TDI on an annual basis, but must be provided upon request. Moving on to the non-quantitative treatment limitations. NQTLs are standards other than explicit numeric limits that act to limit the scope or duration of benefits. For example, a prior authorization or medical necessity standard, step therapy protocols or fail first policies, standards for provider admission into network, including the contracting practices and reimbursement rates, and formulary design. These are all types of NQTLs. The language around parity for NQTLs is a little different. It doesn't talk about predominant and substantially all. Instead, the standard is that such limits must be comparable to and applied no more stringently to mental health benefits than they are to medical surgical benefits. So again, looking at non-quantitative parity, the processes, strategies, evidentiary standards, or other factors used to apply the limit must be comparable to and applied no more stringently to mental health and substance use disorder than to medical benefits. That analysis does still occur within each classification. And you don't just look at how those limits might be written, we also look at them in operation. So if you've written a process or a standard that's equal, but what you're actually applying is not equal, that is not meeting parity for non-quantitative treatment limitations. Outcomes are not determinative of compliance. So data on its own is not itself evidence, but it is a warning sign of a potential operational parity non-compliance issue. So when we think about non-quantitative parity, we do look in each classification, comparing the behavioral benefits to the medical benefits to which the NQTL applies. We ask, how is it designed? What factors, sources, evidentiary standards are used? What is the threshold or the methodology incorporated in that NQTL? And we also ask, how is it applied? What process is used? What is the frequency of the review? What are the qualifications of the key staff? These are all kind of operational ways in which an NQTL might be more restrictive for mental health benefits as compared to medical surgical benefits. So some considerations for non-quantitative parity. How does the plan ensure NQTLs are comparable and no more stringently applied? How much discretion actually exists in practice? Is the same level of detail present for behavioral care and medical care? How are operations audited for consistency with written procedures? What disparities exist in operation, and what incentives may influence the application of the NQTL? Again, getting back to the rules, 21.2438 through 21.2441 address the NQTL analysis that's required by TDI's rules. Each plan must be analyzed using TDI's template or an alternative template as long as they are following the same four-step process and producing documentation that provides the same level of specificity. And again, a single analysis may be completed for multiple plans that contain an identical set of NQTLs. So the rules lay out a four-step analysis. The first step is identifying all NQTLs applied to each mental health and substance use disorder benefit and each medical surgical benefit. Provide specific details regarding the NQTL and describe how the NQTL is implemented. Step two is to identify each factor considered in the design and application of the NQTL. Step three requires identifying the sources, including any processes, strategies, or evidentiary standards used to define the factors identified in step two. And step four is to provide a comparative analysis demonstrating NQTL compliance. So this is based on the federal self-compliance guide. The self-compliance guide and the template in our rules provides a lot more detail and examples. And I think one thing that's important to note is that that comparative analysis needs to be substantive and needs to really demonstrate how the plan has taken a thoughtful approach to parity and a careful approach to the NQTLs that they're applying. The deadline for completing the NQTL analyses is a phased-in deadline. This really applies most to those plans that are subject to the TDI rules, but not subject to the federal rules, like the short-term limited duration plans, the grandfathered small group plans, because under the federal law, as of February 2021, NQTL analyses must be provided on request. But we did provide this phased-in deadline to kind of demonstrate where we think the most urgency is in terms of concerns around compliance issues with these NQTLs. So as of June of 2022, the analysis should be completed for all NQTLs related to utilization review. In 2023, we focus on the network adequacy NQTLs, and then in 2024, any additional NQTLs should be analyzed. But really, if you're complying with federal law, this should already be well underway. And finally, I've provided a link to several resources to TDI's website, HHSC resources, Department of Labor resources, and some resources from the National Association of Insurance Commissioners. And I wanted to, in particular, point to the last bullet, which is a sample of a sufficient NQTL a comparative analysis that provides a really in-depth walkthrough of how to complete an analysis of your NQTLs that provides the level of detail that's expected by regulators. That's all I have today, and I'll be looking forward to answering any questions you may have.
Hello, welcome. Thanks for joining us for our webinar on mental health parity. I'm Ben Gonzalez with TDI's Public Affairs Division. Of course, any questions that we don't get to during today's session, we'll try to follow up later via email. If you think of other questions even later, you can go ahead and email those to lifehealth@tdi.texas.gov. Lifehealth, one word, at tdi.texas.gov. Okay, joining us to answer your questions today is our presenter, Rachel Bowden. Rachel is the director of TDI's Regulatory Initiatives Office in our Life and Health Division. Her team tracks life and health policy issues, rulemaking projects, and responds to proposed legislation. And joining Rachel to help field some questions this afternoon is Matthew Tarpley. Matt is TDI's Chief Market Conduct Examiner in our Financial Regulations Division. And before we get going with the Q&A, one last note. Any questions about a specific company, we're not going to answer those on the air. We'll need to answer those later offline. But again, you can email us those at the address I mentioned earlier, lifehealth@tdi.texas.gov. All right. I guess we can get started with our Q&A now. For the record, Rachel, the Mental Health Parity Act was passed in 1996, correct?
That is right.
Awesome. All right. Here's our first question to you and Matt. What, I guess she'd like a little explanation about the spectrum disorders. I know you covered some of this in the presentation, but are the autism issues specified anywhere? We still have clients that are having trouble getting these things covered.
Yes, I think generally autism spectrum disorder is generally recognized as a mental health condition. And so we would expect health plans to be treating it as such and providing the protections of the parity law for benefits related to autism spectrum disorder. So what our rule did was clarify that, a limit on coverage that might have previously been permitted under the insurance code would only be permitted if it did not conflict with the parity standards. So those benefits would be subject to the parity test for both quantitative and non-quantitative parity. And if you have specific concerns, we always encourage you to file a complaint with TDI so we can look into the issue.
Yeah, that's the way we get into the more details of the specifics of a plan, is to have that complaint looked at and we can see everything in that policy. Next question, is there going to be a change to the template for Division 2 data collection?
That's a great question. We did recently update the template to reflect the 2021 plan year. I don't think that there would be any substantive changes to the template, but there might be other changes needed, for basic, if there was a typo, or I think
cleanup
for like the Medicare rate that's filled in, we might need to update those, but that doesn't really affect the issuer's ability to complete the form. So if there's specific questions or concerns with that form, we do have a dedicated mailbox for that data collection, which is healthparity@tdi.texas.gov. And you can find information on our website about the data collection, the link to the form, and the contact information if you have any more technical questions.
Okay, sounds good. Next question. If a carrier doesn't sub-classify for NQTLs, the data outcome doesn't align exactly with the NQTL. What are your thoughts on this?
That's a great question. So we felt it was really important to have consistency across issuers in designing the data collection so that, when we compared one issuer to another, we understood where there were differences. And in the decision to require subclassification in the data collection, really we could pull that data together and aggregate it if we're looking specifically at one issuer and focusing on one area of their NQTL that's related to that data. Yes, the NQTL analysis you complete might not be exactly comparable to that data collection that's standardized, but I think ultimately we'll look at it on a case-by-case basis, and that data at a high level allows us to look at it on a market-wide basis as well.
Okay, perfect. Thank you. Next question. I read in a federal report recently that Texas was one of 3 states that does not enforce MHPA EA, the Addiction and Equity Act. Is that true? And if so, why is that?
That's a great question. And I'll speak to this a little bit and throw it over to Matt to see if he wants to weigh in as well. So the history of Texas not enforcing the Parity Act really dates back to the Affordable Care Act and how it expanded the applicability of parity laws. So since Texas didn't update its laws when the Affordable Care Act passed, Texas was one of the states where the federal regulators were responsible for enforcing the Affordable Care Act in Texas. And so because the Affordable Care Act impacted the ACA, so too did CMS enforce the Parity Act on behalf of Texas. Now that we've adopted our rules, we do anticipate that eventually TDI will be the point person, the regulator on parity. But obviously these rules, they didn't all take effect on some magical day. The analysis tools that we've provided through the data collection and the self-compliance analyses, those have phased in timeframes. So I think Matt can probably speak a little bit to how the agency will be operationalizing in-depth looks at parity through market conduct.
Yeah, building off a little bit about what Rachel said, the history is what it is at this point. Our exams are going to focus on Texas statutes and rules. And so now with the rules being somewhat recently adopted, and of course, as Rachel mentioned, the ongoing analysis as well as annual data calls, if you will, we're working on building out processes to determine how best to confirm compliance for those. And that, can in and of itself cover a broad spectrum from as everyone probably on this call knows, we do examinations of health carriers every 3 years by statute, building in a level of mental health parity review to existing examinations, as well as potentially building out complex parity focused examinations and using those as tools when we see a potential need for those. So it's something we're working on, and I do think it ultimately will cover a wide spectrum of complexity once we get there.
Okay, thank you, Matt. Well, given the DOL's report that no NQTL responses have been compliant so far, do you have any insight as to how plans confirmed compliance, or is TDI working with the Department of Labor?
We will be, I think, collaborating with the Department of Labor somewhat. We definitely have those lines of communications open with federal regulators. We really encourage issuers to work proactively to ensure they are in compliance with parity. And I think what that means with respect to NQTLs is really saying, are we applying these NQTLs and designing them in an objective way and in a thoughtful way? And I think what federal regulators haven't seen is sufficient documentation. So, when we talk about the factors considered in applying an NQTL, it's kind of saying, okay, so you think this service requires prior authorization. Why? why this service and not this service? So there should be some answer, right? So maybe the answer is excessive utilization. And so then the next question, the step 3 of the analysis is, well, how do you know the utilization is excessive and how do you measure that? What's the threshold? What's the measure? And are you applying that same type of threshold and measure when looking at which medical conditions to apply prior authorization to? So I think there's been a lack of documentation because a lot of these, NQTLs may have existed in plans maybe kind of arbitrarily, or maybe the reason was lost over time. And when they were initially put in place, the parity law didn't exist. And so, I think there's a lot of inertia. And that's one of the reasons that its compliance has been slow. And, failure to provide documentation doesn't mean that it's, necessarily unequal, but the expectation is for plans to provide the documentation to prove it. That's really what the step 4 of the process is show me that this is comparable. So I think inadequate documentation has been the major struggle. And so we hope that plans are working to fix it, that using the guidance that DOL has put out and which has been incorporated into our rules. And as Matt said, when we do exams, we'll be doing our best to hold issuers accountable, focusing on areas that we've identified using the data collection, as well as in response to complaints and trends that we see. If we hear about an issue, we're going to be asking questions, and the rule gives us the tools to ask those questions.
Okay. We're running really short on time, but I have a couple of questions that should be easy. These are just on applicability. Are state programs like Medicaid and CHIP subject to parity laws?
Great question. The Texas law really doesn't focus on Medicaid and CHIP, but the federal law does. So HHSC has a lot of information on their website about how they're looking for parity in those plans.
And in a similar vein, does the federal act apply to self-insured plans or the state plan?
Yeah, so the state law applies to some like the MEWA plans, which would be self-insured, but whereas the federal law applies to all of the ERISA plans that are exempt from state regulation.
Okay, we have several more questions, but I'm afraid this is going to have to be the last one. Is there a specific area within the pharmacy benefits that TDI sees as a problem with regards to parity rules?
Not offhand. I will say it's a little bit complicated. Pharmacy benefits, there is a lot of quantitative stuff around them, but under the rules, they're really assessed using the non-quantitative treatment limitation framework. So if folks are concerned about those formulary designs and whether they're meeting non-quantitative parity standards, we encourage them to let us know what their concerns are.
Perfect. All right. Thank you, Rachel. Thank you, Matt. We're going to have to wrap it up there because it is 3 o'clock. We're out of time. If we didn't get to your question today, or you think of other questions that you'd like to see addressed, please send them to the emails we mentioned in this presentation. There's lifehealth@tdi.texas.gov, and we'll get back to you with an answer if we can. All right, that's it. Thanks for joining us. Have a great rest of your day, and we'll see you in 2 weeks.